On behalf of Pathfinder International, the Global Fund for Women, DKT International, Mama Network, and Women First Digital, I welcome you all to this very important and timely event, Medical Abortions, Putting Power in the Hands of Women and Girls. My name is Crystal Lander. I'm the Executive Director of Global Affairs at Pathfinder International. I'm a feminist, I'm an advocate for social justice, and most importantly, I'm a life learner and so excited for today's roundtable discussion, as I know I'm going to learn just as much as you. Today, we're looking to connect the dots on medical abortion by exploring the critical linkages among the global strategy, feminist grassroots activism, and commodity supply chain. Now, for many women living in the United States, we know there's been a concerted effort to limit women's access to safe abortion services, contraceptions. But we know that this has particularly been strong in the southern and Midwest parts of the country. However, with the recent Texas anti-abortion law, otherwise known as SB 8, gaining national attention, more women in the US are finding themselves in a position of thinking more seriously about access to self-care abortion or medical abortions. Organizations that have been working globally to increase access to safe abortion and self-care abortions and other self-managed abortion services are now seeing overwhelming traffic on their websites from web addresses in the United States, not just Africa and Asia. And as I mentioned, I work at Pathfinder International, where I spend most of my time thinking about what's happening in other countries. I can't help but wonder, as countries like Argentina, Mexico, and Ireland are becoming more progressive on abortion, in my own country, things are going the opposite direction. We have a diverse group of participants here today, and our hope is that donors, advocates, implementers, are all come away with a better understanding of the ecosystem around medical abortions so that we all can better support women, girls, and people of all genders in seeking safe abortion services. So during this roundtable discussion, we'll delve into the role that medical abortion plays in safe abortion access and help with achieving universal health coverage. The organizers hope you'll all leave the discussion with a better understanding of how you can help support efforts to expand access to medical abortion across the globe. So let's get started with the definition from the World Health Organization on self-management of medical abortion. As you can see in front of you, this is the definition. And I'll give you a second to read it. And for our French speakers, you should see that translation for you. So with this definition, we wanted to kind of have a starting place for everyone. Some of the key things to note is self-assessment and self-management approaches can be empowering for individuals and help to triage care, leading to a more optimal use of healthcare resources, aka universal health coverage. To give you an idea of what happens, we have a map of access to registration for misoprostol and mifepristone, and approval, and look at across the globe what these approvals look like. This is as of October 2021. Misoprostol was approved then. Okay, and here's a look at where mifepristone is approved. Now, of course, drug registrations and approvals are just one step toward expanding access to safe abortion, and we'll talk much more about that later. The obstacles to medical abortion are numerous and complex, as are the strategies for addressing them. That's why we brought together experts with different perspectives, but similar goals as to how we build bridges across our distinct areas of work. With that, I invite our panelists to turn on their video and introduce themselves. And I'll start with Claire Crossett. Can you tell us a little bit about who you are, your organization, and how your work fits into this topic?
Sure. My name is Claire Crossett. I'm the Assistant Director for Women First Digital. I'm based in Chicago. Women First Digital is an e-health social enterprise. We work around solutions for abortion care and contraceptive access globally with an emphasis on self-care. And so in thinking through this topic of conversation, we're keen to participate and dig into really how we break down obstacles that exist for people, particularly sourcing their own self-management of abortion care within the broader ecosystem that you've touched on of so many various stakeholders.
Great. Steve, thanks, Claire. I'll go over to Steve. I'll go over to you.
Hi, everyone. My name is Steve Luboya. I'm the technical advisor for compulsory abortion care at Pathfinder with the sexual reproductive health team based in the US. I live in Zambia, and I'm really passionate about sexual reproductive health. I have a 10 years background in providing services, abortion care services, as a provider, as a trainer, as well as a clinical mentor before I joined. I joined Pathfinder 2 years ago as a technical advisor. Very happy to participate in this discussion.
Excellent. Sybil, we'll come over to you.
Thank you. Okay, I'm Sybil Mezi, woman rights activist and the executive director of Generation Initiative for Women and Youth Network. I am also on the coordination team of the mobilizing activists around medical abortion, Mama Network. I'm based in Nigeria. I've been working on sexual reproductive health and reproductive rights of women and girls for the past 18 years. And I've attended workshops, trainings, and met a lot of organizations. I'm glad to be here. Thank you.
Thank you. And then finally, Chris.
Yes, good morning. From Washington, D.C. My name is Chris Purdy. I'm the president of DKT. We are a social marketing enterprise and focus both on the supply chain side of making sure that medical abortion drugs and safe abortion technology is as widely available and affordable as possible in as many countries as possible. And then also really working on the demand side and the training side to empower both health providers as well as consumers to know how to access and make use of those products. So that's the short version. Thank you.
Excellent, excellent. So panelists, you can, participants, you can see we have an excellent group of experts here. So we're going to just dive right in. So if we could put the definition back up on the screen for self-management of medical abortion. And I am going to start with Claire. Could you tell us from your perspective, what do you think of the definition, and is it enough? What's missing? Or maybe what is it missing?
I think it's a good starting point. I think that the definition of what self-managed abortion can be is almost deserving of its own roundtable discussion. There's a lot of layers to it. I find myself still grappling with what I am most referring to when I talk about self-managed abortion. And if I'm being very candid, even though I work squarely in the field of self-managed abortion, I find myself code switching often between what I mean by self-managed abortion, depending on who I'm talking to and what project we're working on. A definition like this from the WHO, it's expansive, it's encompassing, and there's value in that, because what we're really talking about here is a power paradigm shift. You know, it is very meaningful to come from the WHO. This language about self-assessment and self-management can be empowering. That's true, that's valuable. But from an operational standpoint, you know, Women First Digital, we provide various resources and support structures for people seeking medical abortion support. And many of those people are operating entirely outside of a clinical pathway. There's value also in having a very specific definition that means someone is beginning and ending their abortion journey without, clinical support. The person who manages in that sense needs a particular set of resources and thoughtfulness behind how we approach and support them. So I think my answer is that, yes, I agree with this WHO definition. But I also come to this place of what is the true value add of having, a definition that is so expansive that what we're talking about is something more conceptual versus having a definition that really indicates one particular abortion experience.
Wow, that's such a great point. And it's there, and we know it's important to have these standards set, but something like out of reach. Sybil, I'm going to go over to you next. You work with a lot of pregnant people in country. This is real, day to day in your network. What do you think of the definition, and does this make sense to the people you're connected with or you're talking to?
Okay, thank you. The definition of WHO, I think I said recommends that individuals in the first trimester can self-administer mifepristone and mifepristone medication without direct supervision of a healthcare provider. Well, I feel that a mama, we think that according to this definition, it is acceptable and make access to safe abortion, simplified access to safe abortion, because we believe that it's not only at the medical, at the clinic or hospital that women access abortion, because whether it is accessible in hospital or not, women still perform it outside the medical provider's guidance. And most of the time it is unsafe. So it is quite acceptable. In MAMA, we accept WHO definition as we focus on sharing evidence-based and stigma-free information about self-managed medication abortion directly with women on community level. And MAMA is a collaborative of women movements and activists around Africa. So I think the definition of WHO is acceptable because our work is aligned to WHO guidance and definitions and protocols.
Great to know. Okay, so this is getting down to the real people. Chris, I'm going to come over to you next. So from your perspective, you're working a lot at different levels with supply chain. How does this definition play in? And is there anything missing for your work?
Well, first of all, we obviously salute World Health Organization for their bravery to some degree in putting out this at all, because it's not so easy for WHO to do this. They need to consider the many countries and how this will be played out and interpreted. So there's some politics at play here. So I think it's excellent that they've done this at all. It's not a perfect definition. It obviously still focuses a lot on clinical experience. And I think it's fair to say that the vast majority of women who use misoprostol or mifepristone are probably doing it without the benefit of a trained health provider to help them. And in a perfect world, everyone would have access to a highly qualified provider, to give them some advice or to walk them through what can be a very challenging experience and with lots of questions. I think what Sybil talked about and maybe
ce qu'a dit Sibylle.
What Sybil said is the reality and the experience of women is they're going to a pharmacy. Oftentimes they're getting some mifepristone and some misoprostol. They are then going online and they're Googling to figure out what to do. And that's the reality for most women. And so I think in terms of DKT, we're not working in a theoretical construct. We're working where the consumers are, where the clients are, and meeting them at the places that they need. So making sure that the product is available where they can buy it at an affordable price, and making sure that when they type in whatever they type in, or when they visit a health provider, they're getting the services and the information that they need.
Yeah, I'm going to come back to you on that information experience and get more into that. Steve, rounding out with you on this definition for your work, I know you work a lot with governments and with civil society organizations and with, frankly, projects on safe abortion. How does this definition play into your work, and is it well known?
Thank you. I would like to agree with Chris that this is not the perfect definition, but it's a great starting point, because WHO definition kind of opened the doors for envisaging abortion care out of the medical settings, which is something that is really adding value in terms of a women option, which is option beyond just the method of the intervention, but an option in terms of point of care. Of course, the WHO definition is still considering strong linkages of self-care with health system. And I think that is another great area where we need to understand what that linkages mean exactly. What is that the health system should be providing to support women who are accessing these services out of medical settings. But for a starting point, I think this is great. And in terms of what it means for many implementing partners is that most of the health system continue looking at abortion as a very medicalized procedure, and this quite engage us into a new perspective for demedicalizing self-abortion.
Great. All right, let's jump into question number 2. So many things to learn here today and so many perspectives. So Sybil, over to you for question number 2. You talk about the Mama Network, and as you can imagine, a network is keeping everyone focused on the same thing, or making sure that we are using every avenue or opportunity to move this forward. What are some of the advocacy approaches you all take throughout that network that you think is helping to make change, or you think are some of the best advocacy efforts that are happening?
Okay, we use Mama use collaborative, inclusive, and activist approach to demedicalize and decolonize abortion, shifting the power of control to the users and communities, integrating human rights, that is, taking abortion as a right, focusing on abortion access as a right, then using feminist principles, that is, promotes that health equality are just and ethical among different populations, and women require trust and respect. There should be trust and respect for people's autonomy and choices in order to fight stigma, promote women's rights and power. Uses positive language while promoting all existing options like surgical vacuum aspiration, SMA procedures, as it is always up to each person to decide what is right for them. Directly providing with access to products, reliable information, empowers both those who share the knowledge and those who receive the knowledge. In this way, it's concretizing bodily and reproductive health autonomy. In addition, Mama uses harm reduction framework approach to highlight strategies that reduce harm. For example, the harm reduction approach recognizes that taking abortion medicine at home with proper information, life-saving information, and support is safer than illegal abortion procedures. And that if abortion is going to happen anyway, then it should be as safe as possible. Many safe abortion programs in the countries with restrictive access to abortion are based on harm reduction approach. So.
That's great, Sybil.
Yeah.
Oh, sorry, don't mean to interrupt.
Sorry, we can strengthen our abortion advocacy approach to build strategic advocacy line with different stakeholders and actors, which include those working with the people on the ground. For example, local policymakers, community health extension workers, pharmacists, NGOs, social marketers, mainstreaming media, researchers, lawyers, donors, and allies. So that's the integration approach we use.
That's great. You're doing a lot, and we know it's needed. Claire, we've heard now come up multiple times about information using the internet. We know that's where, around the world people go. They use their phones, they have access to get information. But how do we keep people safe too? Because we know everything on the internet isn't correct. So can you talk a little bit about how should we do it? And maybe what do people get wrong with that?
Sure. In terms of how we go about ensuring that people are accessing the right information, it's through collaboration and it's through visibility. The visibility part comes with a whole technical skill set around search engine optimization, understanding user behavior, understanding search queries, understanding how the Google algorithm is changing so that now people are not only searching through typing, but through talk. There's a whole team that's kind of working behind the scenes to understand where people searching for abortion support are going because of the words that they're typing and they're dictating. And then our work is to make sure that we're on the other end of that. We know that there is a strong presence online, as there is on the ground, for anti-choice organizations. And you're right, it's rife with misinformation. We can be vigilant about that. Our team has been in dialogue with Google, with Facebook, taking down organizations that we know that are putting out false information, or they're mimicking, just like crisis pregnancy centers are out there. They have the equivalent online. So we're in talks with digital gatekeepers to make sure that we're monitoring that and those websites get de-indexed, which doesn't mean they're no longer online. It just means that they can no longer come up in Google searches. So from my perspective, in the digital world, there is a whole army of folks who are working on that very specific question and understanding where and how people are using these digital resources. In terms of what people are getting wrong, I mean, I've been thinking about this quite a bit, and this takes me a little bit out of the digital context that I work in, but I've just been struck in the more conversations we're having like these, across often siloed elements of abortion care. I don't think we have group consensus really around what it is we're advocating for often. I'm part of a local reproductive rights network. And a few years ago, I gave a presentation in conjunction with Plan C, folks from Plan C, they're doing great work. They came down and we talked about, what self-managed abortion pills are. We talked about how this is changing in the United States. Overall, very well received. But at the end of the conversation, one of the women in the group came up to me. She was a medical provider herself. She worked as a nurse practitioner providing abortion care up and down California. And she was a generation ahead of me. And she said, I'm uncomfortable with what you're doing. And I don't think that's because what you're doing is wrong when you're talking about the ability for people to self-manage their own abortion. But I want you to know that my generation is the one that fought to get abortion into clinics. And now I'm hearing you and this whole new generation trying to take it out. And I feel like that approach is flippant, and I feel like that approach is very dangerous for abortion care policy. And we sat down and we had a very lengthy conversation, but often I feel like people kind of slip into this dichotomy where to talk about self-managed abortion means to divorce ourselves from clinical care. And I just think that's a dangerous place to go. And we need to make sure that we are keeping umbrella terms in mind and staying united in how we talk about access to care.
Great point. As someone who spent a lot of time working at Planned Parenthood early in my career, it's interesting. I have one perspective on it as someone living in the United States, but completely different perspective as someone who spent a lot of time in low and middle income countries. And so I want to switch over to Steve because I want to pick up on that point around self-managed care versus clinical care. And you work in some of the hardest countries around the world. And the reality is that some of it is perspective. And if your perspective is access to clinics and access to information, as tough as they are maybe to get those resources, we still know it's very different depending on where you're working. Can you pick up on that point a little bit that Claire kicked off around self-manage? Is it a or? Is it an and? And what's the reality like for those things? And then Chris, I'm coming over to you because I want to know if I'm going on the internet to find all this information, where does the pills actually come from? So Steve, you're up next.
Thank you. Yes, self-care is happening, and we know the commonest scenario is a woman getting the commodity from a drugstore or any vendor, and most of the time with inadequate information. So the advocacy focus that we need to look at SPWH definition, first of all, is how do we enhance availability of the commodity? And unfortunately, what we know about where the commodity is registered would not tell us necessarily how accessible is the commodity. And also, even when we look at how legal are the services, would not indicate how much accessible is the commodity. So one thing that we should consider in our advocacy is regardless to the effort we want to make in accessing services out of the medical settings, is to ensure that the public sector first is kind of committed to have these commodities used in the health system, because in many countries you'll find that mifepristone and misoprostol are registered, but the stigma around the service makes these commodities so unavailable in the public sector. But a great starting point would be, how do we work with the public sector to ensure this commodity, first of all, is available in the public sector? From there, we can cascade and facilitate also access in the private sector. And then on the other end, there are no laws, there are few laws that will specify that service should be available in the facility. So most of the regulations that ensure that the services are being provided in the facility are policies, and those policies add barriers that are not even existing in the laws. So our effort is to kind of support government to really understand the legal framework and identify opportunities to remove any kind of barrier requirement that they have put in their policies that are not even existing in the law. And that is quite one thing that the health system are kind of unprepared to consider, because they look at these services as always a facility-based service, even if the law sometimes just say that this needs to be provided by a trained person, without necessarily saying that it should be a healthcare provider. You're talking about a trained person, but you see that policies will now come and add more characteristics or more definitions around who is a trained person. So I think we need to start having conversation around how do we support government to remove unnecessary barriers in the policies that are not even in the law. That can be a good starting point.
Okay, so I'm hearing you say we need both, but the reality is in most countries, it's always considered facility. It's never about self-care. So a little bit, and I see some of the comments coming through on this, and I think it goes back to, we got some work to do, but this is the hope that we keep talking. But Chris, I want to come over to you because we talked about going online to get information. We've gone through networks. Mama is spending a lot of time working with networks on the ground, but we know this is all wonderful, but if the resources aren't there, it doesn't happen. Women will access, or they, even unfortunately would get a bad product. How do you work to make sure we get the right product and support that, but also ensure that we don't get bad products? Or what can we start to do to make sure that is not happening?
Yes. So first of all, I think this is a wonderful conversation because, as you mentioned, Crystal, I mean, connecting the dots and trying to break down some of those silos, because oftentimes those of us working in supply chains, we're not really hearing much about what's happening on the advocacy side or on the care side necessarily. And so it's really important to recognize that all of those registrations that you saw, that wouldn't have been possible if there wasn't a lot of groundwork done by advocates and policymakers and changers to lay the fertile ground for groups like DKT and others to get those products registered and then start importing. And by the same token, once we have those products on shelves, we count on many other organizations and partners to do the heavy lifting on educating consumers about how they can use those products. So it really is an ecosystem, and it's great to have this this cross pollination, if you will. And I would just mention that one other point about those maps that was, I hope, hopefully it struck everyone that on the misoprostol map, pretty much all the countries were colored in, whereas with the mifepristone map, there was a lot of gaps. And so misoprostol is a lot more available than mifepristone. People are trying to change that, including DKT, but it's easier to register and make misoprostol available. So we also need to be aware that there are different products available in different countries. Some products, are easier to register. But to your question, Crystal, about how do we make sure that those products get on shelves? Just like everybody else trying to sell from matchbooks and soft drinks, we have to do the heavy lifting of having resources to register, import, warehouse those products, find distribution systems to get them out into pharmacies, get them out into clinics, get them to other NGO partners, and then by the same token, do the demand creation work. Usually it's through mass media, or these days a lot of it's digital, to explain what those products are, how can you access them, what should they cost, doing a lot of detailing and training of health providers, pharmacist assistants, doctors, nurses, midwives, and making sure that those products are available so that when a woman goes online to a website from Women First Digital or meets someone from the Mama Network, and they say, well, you should go buy this product in this pharmacy, we want to make sure that it's there and that a woman can afford it. So that really is the work that we do. The other point that I would just mention here is, and again, this is where there can sometimes be a schism, I guess, between sort of the rights-based and advocacy-based organizations that are, and the practical sort of, we've got to get these things done organizations. In a lot of countries, people don't talk about abortion care at all. They talk about miscarriage management, they talk about post-abortion care, and we really have to be mindful that that conversation needs to be held up and lifted up as a legitimate way to get at some of these issues, because in a lot of countries, women don't have the luxury of talking about abortion care with their health providers or the systems that are there.
Excellent point. And again, we don't claim that we're perfect. Everyone here is perfect, or we're doing it. The idea is that recognizing how we are all needed in this conversation. I did want to talk, Chris, have you explain a little bit. I wasn't clear enough on bad product. What we're trying to say is we know that with more women, and even, and emphasizing women in the US too, going online to try to get self-care for abortion, we know that there are always people who are lurking online to provide fake pills, fake products, and that's what we were talking about. Ones that are not truly the right products or the correct mixture of those products. How do we? I'll start with you, Chris. Like, how do we increase information online to get products to the right places around the world, but at the same time are careful that we are steering women are not going to get hurt by taking things online that are just not right. And we know that can vary, and we don't want to put any companies' names out, but we know that access is great, but sometimes that access, people take advantage of the access.
Yeah, this can be a challenge in some countries more than others. I think the case of the United States, where laws have been passed that make it difficult for women to access their legal right to abortion, they're going to extreme measures, and people can sometimes take advantage of that, and it's very difficult to control if someone's bringing products from outside. But by and large, I don't think there's a lot of spurious product coming into the United States. And again, I think you need to make a distinction between misoprostol and mifepristone. In general, mifepristone has not, there haven't been a lot of problems with the quality of mifepristone around the world. Where there have been issues and question marks has been around misoprostol, which tends to react poorly in humid situations if there's not good packaging and good sealant of the misoprostol. And the efficacy of that misoprostol can drop pretty rapidly if it's not stored properly and produced properly. And that's where there have been unfortunately some issues around that. Many of us who are in supply chain work have gone to great pains to, to do independent lab testing of this, working with manufacturers to upgrade their, their quality measures. I think a lot of those problems have been overcome. It's not to say that there aren't still some in some countries, but we're working pretty hard on that. I would ask. I mean, I think a Women First Digital. Maybe Claire can speak to this. But when a woman goes to a website and says, "Where do I go for an abortion?" And that's kind of what I think Women First Digital does. So maybe Claire can chime in on that question of quality as well.
You read my mind. Claire, I did want to talk to you about that. And also, when you're answering this around how do we ensure that we, again, steer women to the right websites to get the right information, I want everyone to remember, too, this is a global discussion. So, you can maybe hit up that facility, around near you, or have it sent to your home if you live in certain states of the United States. But how does that work outside of the US? If you could speak to a little bit of both, ensuring that that woman is getting what she's supposed to get in the mail to her.
Yeah, in fact, I can speak better to the global perspective than the United States perspective, because even though in the United States, we don't work, our work is not focused on the US. So Women First Digital takes two approaches with ensuring quality. We are speaking directly to users, and by users, I mean people seeking abortion care. I use the word users because that's what I look at Google Analytics all day. So we're speaking directly to users, and then we're also speaking directly to providers. For our users, we have two websites. One is howtouseabortionpill.org. The other is safetochoose.org. Both are focused on safe abortion information and supporting self-management. Both websites have profiles for, I think, over 50 countries now that specify where you can go to have a safe abortion if there are resources in your country. They also show you images of what safe pills or popular brands look like in your country. That's very important that people can actually see to visually, double check that what they're using is safe. We provide instructions so that people know how many pills they need off the bat. A lot of times when we're talking about like the person out to sell the fake pills, and it's really intentional. Sometimes they're just so often bogus that it's like, take 2 of these. And so if someone just knows how much they should be expecting, that can sort of self-correct immediately. How to Use Abortion Pill also just released a series of 8 videos specifically for self-managed abortion care with Doctors Without Borders. And we talk through 8 very short episodes, every kind of step in the abortion care process. And there is one lesson specifically to, what should I expect as I'm preparing for my abortion and making sure I have the right medications. We show what the pills look like. So that's on the user-focused side. For providers, we also create online training. And right now we're in the process of reworking some of our training with International Planned Parenthood Federation. Currently, How to Use has different trainings for medical abortion focused on pharmacists, medical students, community health workers, humanitarian aid workers. But we realized that inadvertently, by creating courses that are specific to each different role in the healthcare field, we're over medicalizing abortion. And when the course was made, 3 years ago now, so much has changed that needs to be updated. So we're working on a pan provider course. It doesn't matter if you're a pharmacist or a doctor. When people come to you for abortion care, you're saying, for medical abortion care, you're saying the same thing, it's a similar role. And one of the lessons specifically talks about how to monitor for how to monitor for quality, the appropriate steps to take if you're noticing that you're suspecting that the batch of medication you're working with is poor quality or low quality. So just getting really specific with both the people who are using the medications and then also the providers. And as to what Chris mentioned about how to store appropriately, all of those pieces need to be spelled out very explicitly, and just the more visibility and more access people have that information, the more safeguarded they're able to make themselves.
Excellent. And I think a theme about power is having the education, having the tools, having the information. These are all very important. And just note again, for our participants, we'll be sharing a number of the resources mentioned today by our speakers in the summary of this event, because we want you to go and support those groups and check out what they're offering, because we know that, again, this is a very diverse audience here. Steve, I wanted to come over to you, and we've talked about so much, but I want to go back to the theme of bringing abortion and medical abortion and safe abortion out of the shadows. We know it's been brought up that everyone doesn't have access to talk to a provider about this, but how do we bring it out of the shadows enough so that people are safe, but also they have the information that they need, or they know where those resources. Claire talked about some websites. I know that you spend a lot of time in different countries supporting governments who are starting to think these things through, and we're trying to help them do it the right way. So what are some of those ways, based on your experience, we can bring this out and really thinking in that broad audience, we being activists, advocates, implementers, donors?
Yeah, to bring abortion, medical abortion out of the shadow, I strongly believe that the safety wouldn't be, for me, the concern, but the concern will be the access. Why am I saying that? It's because of the indisputable effectiveness of medical abortion, either used in combination regimen or using the misoprostol only, as long as the right information is given to the woman. And then also as long as there's a possibility for the woman to access additional care in case it's needed. So safety wouldn't be maybe the main concern, but it's the access. So looking at the access, I think one thing is to move away from our understanding of a safe and unsafe abortion from the dichotomic view, and try more to think about it as the WHO revision of the concept of safety through the three-tier definition of abortion safety, considering less safe and least safe abortion. That gives us a range and justify different type of intervention, even where we are not able to change the policy and laws. But if we can move a woman from least safe procedures to less safe, and then we are doing something in terms of the woman well-being. So I think if we can move away from the dichotomic approach and considering more conversation around around the different level of safety, we can engage government also to discuss in that line. And we know most of the time governments are prepared to embrace access, even if they feel the pressure coming from religious leaders or the opposition. But they may not come on the open, and sometimes it's important to negotiate. Can I say, is it negotiating to meet halfway? I'll give you the example of Latin America, where the religion is having quite high pressure and abortion is most of the time illegal. But government have moved forward, allowing, for example, access in some countries to misoprostol on the counter. That make really a big difference for women in terms of access, because the law is there prohibitive, and then the community is not supportive, but the government being very much aware of the implication of maternal mortality due to unsafe abortion, kind of open a window by allowing maybe access to this commodity through a counter. I think those are the kind of intervention we need to look at, increasing harm reduction intervention, and also working with the suppliers. Advocacy with the suppliers for me would be around how do we merge availability of both the quality commodity and the information. There have been some movement in countries where maybe the number of women who are able to read are quite low. Where we have some products. Maristop have an example of MSI. Maristop in some country in Africa, Zambia, have come up with a package that have pictorial explanation, a leaflet with a picture explanation to women who are accessing the commodity, so that they don't need any support from a provider to understand how to go about their pills. They can know about the danger sign just by going through the leaflet that is in the package. And I think those kind of advocacy with the suppliers and the manufacturer, I think is very, very important to see how best we can try to merge availability of the information and also quality commodities. I think those are the few things that we are looking at. And I want to say it again, the position of the government is quite important, because all the regulatory agency about for the commodity are parastatal or statal agencies. So it's quite important to have them on board in this different approach of addressing unsafe abortion, moving from the dichotomic understanding to the three-tier definition that WHO provided in 2016, but very less used in many intervention.
Great. And Sybil, I wanted to come over to you. What do you think is the one thing that safe abortion activists can do to support your efforts?
Thank you. I feel safe abortion activists need support and funding to build a global South and a dynamic grassroots-led movement that can expand access to safe abortion through self-managed abortion exponentially.
Great. Chris, I'm going to give you the same question. What can activists do to support your efforts? Because we know they're the ones out there on the front lines many times, but you're behind the scenes in a lot of the supply chain work. So what can they do?
Well, I think linking women on the ground and they're already doing this. So it's linking women on the ground to the products and the services that we provide, linking them to the right information, and probably having maybe a little bit more coordination and discussions among those groups, along with the DKT offices and other folks who are making products available, so that they know what a good quality product is, how much should it cost, where can you find it. If they find a pharmacy in some town where they're working and there's no misoprostol there, we'd like to know that so we can pay a visit. Things like that are very practical steps that can improve things for everyone.
Great. And Claire, what about you?
Yeah, I'll echo what everyone else has said. So like what Sybil said, funding is critical. So we'll start there. Additionally, visibility, engagement. We have all of these digital resources, and the simple act of resharing, of directing people, linking, that's powerful, and it has a lot of ripple effects in the digital world. So that's critical as well. For Women First Digital specifically, we are always on the hunt for more language support. Our websites collectively touch over like 35 languages or something at this point. And we are producing mass amounts of content because, like we talked about earlier, content is how we ensure that we're at the end of the Google search. And so if there are folks on this call who are multilingual or who are content writers, we are always looking to work with volunteers who we know can turn out quality pieces or help us with any sort of language revisions as we just continue to produce on a mass scale.
Excellent, excellent.
Crystal, can I pop in with one point?
Sure.
I wouldn't want anyone to leave this meeting. We talked about safety and less safe and least safe and so on. I wouldn't want anyone to leave this meeting thinking that use of medical abortion, whether it's misoprostol or mifepristone, is not safe. It is extremely safe to use. Even when you are, when you're in a situation where you're taking it by yourself, it is extremely safe to use. In fact, it's probably safer than being pregnant in a lot of countries. So it's not to say that there can't be work done to improve the experience of women. The definition, I actually disagree with the definition of least safe and less safe that the WHO is using, because they're saying that if a woman doesn't have a health provider, that's least safe. And I think that's not necessarily the best definition. I understand why they are politically, tied to using those definitions, but they are not, I don't think it's accurate. So I just don't want anyone to walk away from this meeting thinking, wow, medical abortion really, maybe it's not safe. That's not true.
Yeah, and I think I want to make sure we're clear too, when we were talking about pills, we know that there's always, like everything else, there's black markets for everything. And our goal is to make sure women and people who get pregnant have the right resources, the right websites to go to. And that's a big part of our role in all of this, is if we don't have the resources, you'll get them pretty soon, so you can send them to the right places. And I think particularly I'm hearing this so much more for women in the United States, that now all of a sudden they're thinking about some of these things a little bit more because of laws and policies that have changed in this country. So now you have them maybe connecting with those from around the world on this very important self-managed piece of all of this. So Claire, your hand is up. You want to get back in on this?
Yeah, I think I just wanted to double back. I'm reading through some of the comments, and I know that in an earlier point, I talked about the importance for self-managed abortion and clinical abortion not to be framed as if they're in tension with one another. And I want to go back to be sure I'm being understood. I think self-managed abortion can exist entirely outside of any clinical touch points. If that's how a person either needs to or wants to have their abortion experience, I think that abortion medication is safe enough that we can trust people to manage their abortion. We can get them the right information, we can get them the right resources, and there's no need for them to have an in-clinic experience. And that's okay, that's very valid. What I meant with needing to work side by side with clinical providers is that it goes back to our definition around self-managed abortion and sort of what is it that we're talking about. If we're talking about self-managed abortion holistically as an umbrella term that captures really this power change so that the person having the abortion gets to dictate the terms with which they're proceeding, then if they feel most comfortable going into a clinic, by all means, if they want to pick up their pills there and then go home if they have that ability, or if they want to have the abortion at home and then get in touch with their doctor, that's fine. But we need to allow that integration to be organic and driven by the person having the abortion so that we don't wind up in this sort of strange infighting within our field saying like, it needs to stay in clinic, no one needs to stay out. It needs to be left to the person to decide what it looks like with as many resources as possible.
I think that is a huge point, and well-meaning activists, we've all been there, will sometimes over or choose for women or choose for people without well-intentioned because we think maybe this is best. I think it goes back to letting the person decide and offering as many choices as we can that are all safe and accessible. Steve.
Yes, I think, not that repeating my colleagues, I would say that the activists should really consider working deeper with community networks. What I mean by that is a lot is already happening in community networks in terms of information sharing, in terms of also women who had an experience either out of the clinical setting or in hospitals about an abortion, sharing with other women. If we could have the activists working closer with these community networks for pushing in their information, facilitating access, and also the global networking that could allow them to benefit from some of the advantages that they may not have in country in terms of access. Give you an example of availability of quality productive misoprostol in between two countries in Africa that I know well, Tanzania and Zambia. Despite the favorable law in Zambia, women do travel to Tanzania to access the misoprostol because misoprostol is quite accessible in Tanzania than in Zambia, where the law is favorable for abortion. So if the activists could work toward facilitating those kind of information, facilitating those kind of access, I think we could benefit from the neighborhood countries and benefit from the position that each of the country has in terms of availability of the commodity. Another thing about I don't want to get back to the definition of safety and safe abortion, but I strongly feel like the role of the activist should go beyond this partnership with the community, but also seeing how best they could trade with partners like NGOs in terms of visibility, because I feel sometimes it can be a problem in terms of understanding what are the funding sources. So how do we have these activists owning the program in a way that they would not finger point the partners behind them for the work they are doing, because sometimes lack of ownership would make it looking like, oh, so it's Pathfinder behind this organization. It's so if we have more activists really having a self-driven agenda, I think there will be less finger pointing to the partners behind supporting their work.
Great. Okay, you all have just been fantastic. And so now I have to give up my power here and turn it over to the audience, who, as you know, has been busy in chat. So I'm going to kick off the first question. And Steve, I want to have you and Sybil tackle this one, particularly around traditional and religious systems set up in Africa, and a bit of how do you work? It says, how do private sector advocates and influencers, civil society organizations go past all the deep-rooted myths and misconceptions in your work? So I'll have Steve, you start, and then over to Sybil.
Yeah, with the religious leaders, one thing that we should keep in mind is the advocacy goal will never be for them to allow abortion, because they will never allow it and they will never support it. But it is how do we have them tolerating, understanding the implications of unsafe abortion in women's life, and how do we enhance that tolerance? I think the strong tool that we use with these leaders and the opinion influencer is VCAT, and also building these VCAT by using local data, real stories, scenarios, and so that they can get to understand what women are facing in their context. So getting tolerance from these leaders is quite an important thing to do, and keeping in mind that they'll never support you on the open. You never expect them to support you on the open, but you can gain the solace. I think that's the strategy.
Great. And Sybil, how do you all do that through the Mama Network?
Okay. We expand activism by ensuring that the information is the safety, life-saving information is everywhere, for example, in pharmacies, in clinics, so that women can have access to it. And we do capacity building training, because evidence have shown that women and community health workers and midwives, including women themselves, can be trained to use abortion pills to safely terminate a pregnancy, thus giving women back the control of their own bodies. And we democratize information sharing by translating the protocol into native local languages and native languages. And we also incorporate to minimize criminalization and risk. And in fact, the boundary of what the law had said and what the law had not said, we coordinate and train a network of lawyers with expertise on self-managed abortion. Yes, and we also share evidence-based stigma-free information through research. Because recently, through Mama Network, we have done series of researches on safe and effectiveness of self-managed abortion, safe and effectiveness of misoprostol, and quality of care of the Mama group of hotlines.
Thank you. Chris, how do we, and sorry, we're going through these fast, you all been great. How do we tackle the obstacle around prescription? Really, it's about access in the public sector. So with supply chain, how do we get access if it's not in the public sector? Do you work with the supplying public sector or just private sector? And then Claire, on the flip side of that, when Chris is done talking about how do you all get around prescription access?
So we do sell to the public sector in some instances, but I think it's worth pointing out here that the vast majority of people who access abortion care or who are seeking abortion care are doing that in the private sector. There are a couple of countries where that is, a little bit less the case, but by and large, it really is the private sector that is providing those services, or the civic sector, if you will, and nonprofits, NGOs, and NGO clinics. So governments tend not to be big providers of abortion care in general, and certainly are not the innovators in the self-care space around abortion care by any stretch of the imagination. The one thing I wanted to raise as an issue is about price, because this is the cost of medical abortion and what should women pay for medical abortion. And I think there's a lot of different ideas about this floating out there, and I'm certainly on the receiving end of a lot of those conversations about, you know, how much should it cost and what should it cost. And I'm kind of curious to ask not only the participants, the speakers, but also some of the viewers here. You know, what do people think? What do you think is a reasonable cost for you know, if you go to a pharmacy and pick up a you know, pills that are going to terminate a pregnancy? What should that cost? And should it cost 25 cents? Should it cost $25? Because there's a lot of debate about that, and price point is a major part of self-care, right? The cost of the abortion, the drugs, getting them there, making sure that the pharmacy has an incentive to sell them and stock them. That, you know, doctors don't provide services for free in most cases. So I think that's an important question to ask.
All right, Chris has put out a challenge to you all. I know I've seen some of these names in here. I know they're going to give you feedback on that. But we'll wait to see it come through. Claire, second part is, what about prescriptions? How do you get those, the pills with the prescription needs?
Yeah, you know, people have been getting access to pills without prescriptions since abortion pills were around. In the 1980s, women in Brazil were reading the labels on their gastritis medication and realizing that a side effect was pregnancy termination, and then they used it as such. And huge networks came out of that to support, you know, self-managed abortion with pills. So from our perspective, Women First Digital, we're not necessarily in the space of coaching people how to get around prescriptions. We know that people are often finding their own ways around. And our role is often to verify that, okay, this looks appropriate. Yes, this is the safe way to use it. But I want to specifically mention one of our platforms, safetochoose.org. They provide multilingual abortion counseling. So anyone who is having an abortion or they're planning to have an abortion can type into a chat. And I think we're in 12 languages now, so they can be walked through the whole process. Not only are they live chatting, but they have now a provider network that I think it represents over 75 countries, 3,000 providers, 200 provider organizations, that they can geolocate their users to the closest facility and say, you know, if you really want to make sure that you're having, you know, appropriate access for the right medications, here are people that we've pre-screened that we know are pro-choice, and we trust their quality. So again, getting back to just how we continue to trust people to make their decisions and surround them with as much resources and information as possible.
Great. Steve.
Yes, I just wanted to add something around how we can make this advocacy work acceptable. In many settings where abortion remains so much a taboo, I think we have quite a huge benefit of integrating abortion in a SRH package. Advocating for abortion in the SRH package. Example, in Asia, some countries are talking about the SRH self-care package. SRH self-care package that is inclusive of emergency contraception, breast self-examination, and medical abortion by menstrual regulation. So sometimes just the language is very likely to enhance acceptance of abortion advocacy, and then also packaging it within SRH agenda would make activists, even ourselves, more tolerated in terms of what we are doing to advance access to safe abortion. And this is even valid for the way we do VCAT, value classification and data transformation. When you have conversation with decision makers or research designers that are really focused on abortion, you are likely to enhance the resistance than if you are having a discussion in a more broad perspective where abortion fits in a SRH package. Where they can understand the connection between access to family planning, access to safe abortion services, and then access to SRH information.
Great. And Sybil, what has been the role of like feminist movements and gender justice movements? How has that helped your work across the network? And even further, has there been particular campaigns and has that worked to expand access throughout your network, and in some countries more than others?
Okay. All right. Mama Network has membership in 25 countries with 56 organizations. So we we promote the health equality and are just ethical. We promote health equality and believe that it is ethical for different populations to have autonomy to choose and have respect about their autonomy. In campaigns, recently we did a conference, Mama Conference, that brought together 40 Mama member organizations and from 17 countries. And there was a pre-conference before then that we linked and learned with each other. Recently also, the Mama Network joined Global Safe Abortion Dialogue. We joined International Day of Safe Abortion Campaign, which are global. These campaigns are global to link with the global world and link and learn from the global society.
Great. And have the feminist movement and the social justice movement, is that integrated in with your work, particularly across your network?
Yes, we have amongst the membership, we have feminist movements, we have gender justice movements, because one of the approaches of Mama is inclusiveness. So, and empowerment. We believe that human rights alone cannot cover with human rights framework, it does not bring all populations together. So Mama also added empowerment, because they feel that it is empowering to give information, it is empowering to give counseling, because Mama group of hotlines give counseling, give information, and let the user make her own decision of the option she wants when she's faced with the issue of unwanted pregnancy. So I think this is empowering also. Having the ability to make one's own decision, having the ability to decide on whether to have the child, when to have the child, or how to terminate a pregnancy.
Great. Chris, a specific question for you on DKT strategy in Mexico. Already 4 states are integrated into the CDMEX plan. Could you tell us a little bit more?
Well, so as many may already be aware, Mexico recently legalized abortion care beyond Mexico City and Oaxaca, and I think one other state. So we're actually in the process in Mexico of taking a page out of some work that we're doing in the United States, where one of the other hats that I wear is for an organization called CARIFEM, and we do teleabortion work, telemedicine work here in the USA. So we're looking to see if we can do that in Mexico and provide teleabortion services throughout Mexico, including if anybody wants to cross the border from Texas, they're more than welcome to do that and get services that way. So we are working on that. It will take some time, but that's where we're headed.
Great. And for the Mama Network, how are you funded? And a question came up around donor funding for medical abortion, which we can send out to everyone. Who's funding medical abortion and information in it? But we'll start with Sybil. How is the Mama Network funded, and what are your funding needs?
Okay. Mama Network funding is diverse. Normally, when there is a call for proposal, Mama Network will write application for proposal, and if it is positive, if the proposal is positive, they will receive the funding. Right now, the major funders are Amplify Change and Safe Abortion Action Fund and other funders too. And what we really need now is the funding be as flexible as possible. And we are planning also to make it as diverse as possible. Because if not, the grassroots organizations, we have 56 organizations, grassroots organizations. And for them to work, some of these organizations don't have access to funding. So what Mama does is to on grants to these organizations so that they can carry out their work effectively. So if the fund is made as flexible as possible, then Mama will have the confidence and the assurance that these grassroots organizations will continue to work.
Great. And for everyone, who is funding maybe the specific work you're doing, but who is funding more informational medical abortion, expanding access, supply chain for medical abortion? Are these networks? Are there individual donors? Are there more foundations? And yeah, I'll just start there. Claire, kick it off to you first.
Sure, yeah. Women First Digital is donor funded. We actually are in the process of sort of re-understanding how we can offer our services as well to increase our net in terms of the different channels of funding that we have available to us. We're starting to explore not only obviously working directly with donors for specific target regions and mandates, but also working side by side with established SRH organizations that may already be on the ground and approaching partnership as if WFD is the digital component to some, to on the ground strategy. We know that because we work in the digital space, we can circumnavigate many on the ground restrictions that brick and mortar organizations have when talking about abortion, when guiding users towards resources. So our approach is wide, but yes, we are donor funded. And if anyone on this chat is interested in talking about various partnerships, please follow up with me.
Excellent. Chris.
Yes, I mean, I think there's sort of a usual suspects of donors who are involved vocally in supporting safe access to abortion care and post-abortion care, and we I think DKT certainly gets some support from many of those. We get some support from the Swedish government. They're a big supporter of DKT. The Children's Investment Fund Foundation is a big supporter of DKT. And in certain countries, it could be the Dutch government, or it could be other bilaterals, other foundations. So there's quite a range. I should point out that about 70% of the work that we do globally is actually funded by sales revenues. So it is the customers who are our biggest donor, if you will. When a woman buys a pack of medical abortion pills, we take that money and we go out and we buy some more medical abortion pills and import them again and sell them to someone else who pays us for them. We go out and buy some more. So that's about 70% of the total operating budget of DKT, and it provides us with some semblance of sustainability, but we still need donor funds to do some of the heavy lifting, last mile work and things that need to be subsidized. So.
Great. And Steve, to you, and I'll add on, is there a way to get governments to cover this in their budgets? And is that happening with any governments?
Yeah, funding for medical abortion supplies is quite a challenge. Even among donors who are supporting access to safe abortion, you'll find that there will be a fund available for trainings or medical monitoring of services, data improvement, and so on. But quite limitation in terms of availability to finance procurement of abortion commodities. That is one of the key challenges we found on the ground. Of course, there's some few opportunities existing with UNFPA that is supporting about 54 countries with abortion commodities, but the quantity then again there doesn't meet the projected demand in those 54 countries. Recently, the Clinton Health Catalytic Fund has come up also with opportunities for mid-income countries to scale up and introduce the use of the combi pack, and with a focus on pre-qualified or quality assured commodities. These are quite good opportunities, but a few countries have yet managed to have a proposal approved around this. We are all supporting various government to be owning these processes, as it's quite a requirement that government is owning the process, so that a UNFPA or SHI could come in to support with the supply. But I would say also broadly that any work we do around comprehensive abortion care, even if it's post-abortion care, could contribute to this agenda of scaling up access to quality commodities. I'll give you the example of what we are doing in Tanzania with a post-abortion care program, where we managed to introduce the use of misoprostol, while the country had policies that did not recognize misoprostol as a recommended commodity for uterine evacuation. After 3 good years of advocacy work with the government, we managed to have it introduced and recognized in national guidelines. And for the first time, the past few months, we are able to see in the government data system women being served using misoprostol alone for post-abortion care. Having the misoprostol available on the ground for us, it's a good entry point for women even to access self-managed abortion, as it has been well demonstrated in Latin America, where the broad availability of misoprostol has lessened complication due to unsafe abortion, even if the rate of unsafe abortion have not yet changed. But at least in terms of the women experience, availability of commodity make a big difference, and any abortion programming could contribute toward that.
Great. Excellent, excellent. So we have a few more minutes, and I wanted to definitely open up to the panelists to ask a question of one another. I think we've covered everything people had here. Last chance for any burning question, put in the chat. But to the panelists, is there any question or you want to bring up to one another, or a point that was raised that you want to, because I know the chat's been quite busy, that you wanted to bring back up to the group? One question for you, Chris. You saw that. Do you want to talk a little bit about government buy-ins? And is government buy-ins all about just money?
Well, Ben's putting me on the spot with that question. Yeah, I mean, I think, it takes a village, right, to solve these problems. I think we need to have as many actors involved, and we certainly wouldn't want to have all the eggs in any one particular basket, because if you drop the basket, you've got no eggs left. So I think there are many solutions to solving for the financing of medical abortion, and I think financing the medical abortion it's a big piece of how women and people who are getting abortions are struggling, figuring out how do you pay for them, whether that's in the United States or in DR Congo. I mean, it's the same issue. So bringing down the cost of medical abortion itself is one step to that, but really that's not the major cost of getting an abortion usually. So I think there are different ways to go about it, and certainly the other benefit of having many actors talking about this and involved in this is it helps to destigmatize it, whether that's at levels like WHO and ministries of health or community groups or among around the dining room table. All of that helps in that process.
Excellent point. And another question that kind of came through was, there's no panacea, but I think I can answer. But from your perspective, are medical abortions the panacea? Is that for the future? And it was particularly talking about the US, but I think taking it globally, are we going to be moving toward medical abortions as the only access so that women can do it in privacy and have safety without some of the politicalization that we kind of see? And I'll start with you, Steve, on this one, and then come over to you, Sybil. Is this the direction we're moving in? For abortions,
Okay.
will it all be medical abortion?
Yeah.
Or simple, go.
Okay.
No, you start. Go, you start.
All right. Okay. In Mama, we believe that in safety, and we believe in safety. Medical abortion can be clinical or self-managed abortion, because one cannot do without the other. If a woman is accessing through in the home and there is an issue or it becomes complicating, she will be rushed to the clinic. So I think it is interwoven. Both of them, let both of them stay for safety of the users.
Yeah, great point. So clear, there's still a role for facility care and others. Steve, what do you think?
Yeah, I wouldn't want to disclose the new definition by the WHO of self-care. It's coming. I strongly believe that by the end of this year, the new guideline from the WHO will be released. And I was lucky enough to be previewed to the draft, and I'm so happy about some of the things that the WHO has considered in terms of existing evidence around self-care, to include in the coming soon definition of self-care. And one of the things that we need to look at, the growing evidence about the safety, even beyond the 9-10 weeks limitation that some partners are considering, and also looking at how safe it is to use both either misoprostol combined or misoprostol alone. And then also looking at self-care as a range of processes that have different compartments. One is the information, the counseling. The second one is the access to the commodity and the abortion process itself. And the last component is the follow-up care. So the challenge that we may really highlight in terms of follow-up care is how do we ensure that women have contraception after an abortion, and how do we support them if information or facilitate access for if the contraceptive method they might need after an unwanted pregnancy. We need to continue reflecting on how best we can adjust our self-care intervention to that. And then the second thing is in terms of acceptance, sometimes most government will be very tolerant or will be open to looking at introducing self-care on the last piece of the process in terms of follow-up care. I'll give you the example of what we've done in Mozambique during the pandemic of COVID-19, where a follow-up visit were kind of a requirement for all women that were accessing the medical abortion because of COVID-19 impact. Then most providers, most facilities stopped from asking women to come to the facility to get their follow-up visit and just make phone calls to ensure that women are given some support information to be reassured that the abortion was successful. So starting conversion from the follow-up care can be a starting point to grow to grow evidence about the safety of self-care, and from there move forward also the possibility of women accessing the commodity in the absence of provider support, as long as appropriate information is available. So what I would say, if we are able to look at self-care as a full package and tackle it where it's feasible in the portion that is accepted, that would be great, because the African context for the many countries I'm supporting is showing that it's a well accepted model. Self-care is already happening, but few countries might be ready to do it on an open. So how do we support this process while it's quite difficult to do it on the open?
Great points. Chris?
I just wanted to add to that a couple of points. One is, I mean, everywhere where medical abortion has been introduced, we've seen use of it go up, and we've seen, you know, a decline in a corresponding decline in the use of in-clinic methods or, you know, manual vacuum aspiration. And you know, if you take Scandinavia, you know, 90% of abortions there are with the pills. In the United States, I think we're up to about 40%, and this is true everywhere where it's introduced, and that's a wonderful thing, and we're all supporting that. But I think we also have to be mindful of the threat that you know, MVA in clinic abortions, EVA is still very, very important. And there's a big drive by funders and by organizers, and everyone's very excited about the sexy new thing about medical abortion, and I'm certainly one of those people. But we wouldn't want to create an ecosystem where all we've done is train people on medical abortion and forgotten to keep training providers on surgical methods or in clinic methods with MVA. And as I know a little something about this because DKT is also the international, we sell the iPass, manual vacuum aspiration technology in 100 countries all over the world, and we can see the impact of medical abortion on that. And you need to keep building up the skill sets of health providers to provide, because some A's are going to be incomplete. They're going to need to go to a clinic and have post-abortion care. So it's very important that funders, advocates don't forget to keep pushing for all the options on the table.
Yes, you're getting a lot of dittos on we cannot lean one side or the other. And I think that was a point that someone was trying to make, that it's not one or the other, it's both, and we have to keep it up. Claire, you have the last comment.
It's a lot of pressure. I didn't mean for the last comment. I just wanted to echo what Chris was saying and come back to, we need to continue centering people who are having abortions. And I think from a SRH field, like Chris said, self-managed abortion, it's kind of a sexy new thing. There's a lot of interest, and rightfully so. It's creating pathways to care that didn't exist before and at a scale that didn't exist before. But there are people who are having an abortion who'd prefer to have it in clinic because that feels safer to them, or whatever reason. And that, again, is very, very valid. And it cannot lean too far in one direction. It has to remain a unified, integrated service option.
Excellent. Perfect point to end on. You all did exactly what we hoped you would do, which is get us talking. The reality is we need all of us in this conversation. We need to make sure we're educating donors on all of the things that are needed in a puzzle, not just one piece of it. We need more funding for not only medical abortion, but we need funding for advocacy and feminist networks and support. We need support to governments so that they can be upfront with some of this work that they're doing. I am so grateful to all of you, Chris, Steve, Claire, Sybil, and to all of our partners, all of our friends on the online. We see so many of you. Thanks for staying with us to the end and asking such incredible questions and great comments. Thank you again to those who partnered and to our staff who are behind the scenes on the translation. We appreciate you, as we really wanted to make sure we made this in more languages than English to increase access. Again, not perfect because we could do more languages, but we want you to realize how important it is to have these kinds of sessions in multiple languages. So thank you for joining us, and we look forward to the next conversation.